Good day, my dear postgraduate students. The topic for the day is mast cell in health and disease. This is an essay question for the postgraduate students. These are the subheadings which we shall and will remember. Also, of great importance will be the cross references where this topic shall take us to. For example, type 1 hypersensitivity, bronchial asthma, mastocytosis, mastocytoma, as well as the mediators of inflammation. All these are also university questions for us. So, by knowing one, it is an advantage to answer another question. I hope this picture is a little familiar to you people. We are being exposed to a plethora of allergens or antigens. And let us forget what kind of an epithelium. Of course, I am finding a ciliated epithelium. But then there is a series of actions that takes place which brings in a lot of these inflammatory cells of varying nature. And they also release a number of mediators with different functions. But what we shall be concentrating upon is the mast cell, which is getting degranulated in this. Obviously, this is a case of a bronchial asthma, and this will be leading to a bronchoconstriction, a vasodilation, an edema, an increased amount of secretion, and so on. Therefore, the moral of the story is correlate. And this is the reference for the wonderful picture. The history taken from Wikipedia. I would like you people to again, please do remember this. Do not blindly download any kind of information for a seminar or an answer. You shall align them, you shall arrange them, and you will have to deliver the goods in your own words. The synonym for this is a mastocyte or a labrocyte, discovered by Paul Ehrlich in 1877. This gentleman later on in 1908 won the Nobel Prize. And look at his contributions. It varies from bacteriology to anaphylaxis, from syphilis to chemotherapy. Amazing person. Earlier it was thought that the mast cell is the connective tissue counterpart of the basophil. But then these two were found to be from two different lineages, though both of them share a common precursor of CD34. The mast cell is similar to the basophil in structure and granules. The granules being mostly containing heparin or histamine, derived from the myeloid stem cell. Even cells can be of a multi-personality disorder. Look at this. This is of great importance. I would like you people to kindly spend some time on this. The basophil and the mast cell, are they same or different? What I find here is there are a couple of receptors. The KIT and the interleukin 3 are different. But then there are some mediators from the basophils alone, some mediators from the mast cell alone. I would like you people to kindly adhere to some mediators with which you are familiar. For example, chondroitin sulfate. Whenever there is a basophilic matrix, there will be chondroitin sulfate. Basogranulin, as the name goes. Interleukin 3, 4, 31, etc. And there can be the heparin, tryptase, chymase, cathepsin G, etc. from the mast cell. There are also a common set of mediators for both the basophil as well as the mast cell. That is histamine, granzyme B, amphiregulin, leukotriene C4, etc. Platelet activating factor. So these we shall be remembering. So you do find that there is a multi-personality disorder over here, and why not at the cellular level also? Now look at the plethora of functions of the mast cell. It can be allergy, anaphylaxis, wound healing, angiogenesis, immune tolerance, defense versus various pathogens, permeability to the brain tumors. And here I am finding the origin of the mast cell. It is a bone marrow derived precursor that is leading to the tissue counterpart, namely the mast cell. You find that there are receptors which we shall be talking about, and these are the IgE antibodies which get attached to. Initially, the mast cells have got immature granules. Later, they develop into mature granules. Just like your promyelocyte, immature granules, myelocyte having mature or secondary granules. So this is the stem cell that is leading to the origin of this. The functions again continue. Normally you find in a mast cell, there can be an attachment of one of the antigens. It can get fragmented and lysed, as we are seeing in this. There is no degranulation of the tissue. But in certain other cases, I find there is a re-exposure of the similar antigen or allergen, which cross-links to the adjacent antibodies. As a result of which, there is a contraction of the cytoskeleton leading to liberation of the granules. What is being described here is like this. Clustering of the intracellular domains of the cell-bound Fc receptors. So there is a cytoskeleton which is bound to the Fc receptors. These undergo a contraction leading to a degranulation. DAMS means damage associated molecular proteins. Thanks to Wikipedia for this text. The mast cell mediators, there's another list, but I would prefer the list on personality disorder. That is one. There is another one which I would like you people to remember. So this is the epsilon, immunoglobulin, and then there is Fc epsilon R1, which has got a high affinity for the IgE. So this IgE getting attached to this, and it mediates the signaling cascade. Various things are being produced. And what will be important will be ITAM, which is written over here. Initially, I thought it was IT asset management, whereas in immunology or molecular pathology, it is immunoreceptor tyrosine based activation motif. Quite difficult to remember. The functions: allergic and parasitic disorders, inositol triphosphate leads to protein kinase C, contraction of the myosin, and degranulation. So these are all shown here. This kind of a picture you people should draw. So there is an IgE, there is a receptor for it, there is a cross-linking, and then a degranulation. This again is being shown. Initially, you find that there is a sensitization, but later on, you find there is a production of the antibodies which get attached to the mast. But subsequently, when the same antigen is getting included, you find that there is a cross-linking of the adjoining antibodies which lead to degranulation. A wonderful concept, easy for us to remember. Apply this in bronchial asthma. The mast cells can be seen in the neuroimmune system as well as the GIT. So I find that there are the visceral sensory structures in the pituitary, thalamus, hypothalamus, pineal gland, etc. And the function is it stimulates pain, immunity, autoimmunity, inflammation, and the gut-brain axis. In the gut again, it is close to the sensory nerves. So there are the various receptors as mentioned over here, and when these are getting activated, you find that there can be a release of histamine, serotonin, etc. There is a visceral hypersensitivity. Sometimes dysmotility can be there. Degranulation can lead to the release of the various cytokines and the leukotrienes. Other areas where I can find the mast cells can be skin, lung, CVS, and breast. In fact, this has been useful in many of these studies. What we should be remembering is there are a set of enzymes and then their functions. This kind of an entire list is difficult for us to remember. Just remember what I have marked with a dash and an asterisk. For example, SEC tyrosine kinase targets multiple proteins and causes their activation. Inositol triphosphate elevates the calcium levels. Lin tyrosine kinase can phosphorylate ITAMs, and it leads to the activation of syn tyrosine kinase, which again proceeds as follows. Also, you find there can be a protein kinase C, which activates the myosin light chain, leading to the contraction, granular movements, and their disassembly. There are various mast cell disorders which we shall be having in mind. Mast cell activation disorders, allergic disorders, type 1 hypersensitivity we have already seen. Pseudo-allergic is something that mimics. There can be a spectrum of immune disorders of varying pathogenesis mediated by IgE. And then there also can be a tumor called as a mastocytoma. The symptoms of mastocytosis or mastocytosis associated symptoms can be all this. There is systemic, which is basically an anaphylaxis, type 1 hypersensitivity. Dermatology, also a type 1 hypersensitivity, itching, hives, etc. Cardiovascular, there can be a shock. Pulmonary, wheezing, obviously in bronchial asthma. Musculoskeletal, there can be degenerative, osteoporosis, osteopenia, etc. Gastrointestinal dysmotility, diarrhea, etc. can be there. Neurogenic cognitive difficulties, dizziness, vertigo. And this again is a very beautiful picture that has been taken from the Wikipedia. In this, I am able to appreciate the flushing, etc., and the edema in the periorbital region. Beautiful picture for us to follow. What is a mastocytoma? It is a tumor of the mast cells derived from the stem cells. And in this one, I am finding it is a cutaneous variant. I am finding a maculopapular region. So these are something that are above the surface. Multiple nodules are there, maculopapular, and it can be associated with UPR urticaria pigmentosa. Mastocytosis is a clonal proliferation, and it has been described by the WHO. It can be cutaneous and systemic, as we shall be seeing in the staging. Look at this one. So there is a tumor over here composed of large, almost clear cells, amphiphilic pale cytoplasm, and elongated or ovoid nuclei. Most commonly found in the dermal pancreas, courtesy web pathology. The etiology is not clear. It can be because of the growth factors or the interleukins. There can be an inhibition of mast cell apoptosis. Whenever an apoptosis is there, you find is being inhibited, there can be a proliferation. Somatic mutation c-KIT gene. And c-KIT mutation can lead to the change in the D816V in exon. So it is both in the adults as well as in child. So this again is a tumor less than 2 years of age is the patient's age, and it can be associated with the urticaria pigmentosa, more common at birth, so much so it can be mistaken for a vascular hamartoma grossly. Maculopapular and nodular lesions. On rubbing, you find that there could be a release of a lot of these mediators leading to clinical manifestations. The histopathology runs like this. Papillary dermis is infiltrated, dermal edema is there along with eosinophils. Always when there is a hypersensitivity, remember eosinophils. Perivascular, spindle to round cells are there. Mitosis is sparse, it is usually a benign tumor. Atypia indicates a malignancy. Tolidin blue and GMSR. Tolidin blue is one of the most common stains used to demonstrate the mast cells. And CD2 is positive for neoplasia. CD25 can be demonstrated by means of flow cytometry. c-KIT by means of immunohistochemistry. The differential diagnosis for this is xanthoma, melanocytic nevus, etc. And there can be the release of the histamines, which can be treated by steroids, phototherapy, or epinephrine. This is the staging of the disease. Just like the Ann Arbor's classification, you find initially stage 1, there is only one lesion and there is no lymph node involved. In stage 2, there is a skin along with the lymph node. Stage 3, you find multiple cutaneous lesions or cutaneous and the lymph node. Whereas stage 4 is widely metastasized. And this incidentally is a cutaneous mastocytoma. This is a classification of mastocytosis. Mostly it is cutaneous 80%. It can be systemic in 20%. There can be a combination as I had shown you in the staging. Maculopapular cutaneous mastocytosis, diffuse, it can be mastocytoma of the skin. I had shown you a gross picture of it. Systemic mastocytosis, it can be indolent, it can be smoldering. Sometimes it can be associated with a hematological neoplasm. Aggressive systemic mastocytosis can be associated with mast cell leukemia, as we are seeing over here. I am finding large cells with a granular cytoplasm, and it almost looks similar to a basophil, but it is much larger compared with the R.A.T.S. Mast cell sarcoma. Courtesy web pathology for both of these. The history and the physical findings will be most common in the trunks, and I find that there are the maculopapular lesions. The Darius sign can be positive. There is a local itching, wheal, and erythema around the lesion. And the differential diagnosis can be mastocytosis, xanthogranuloma, histiocytosis X, and leukemia cutis. These can be there. Telangiectasia macularis eruptiva persistens. It is an extremely uncommon variant of this. And these again are the symptoms. So this kind of lesions, it can be mistaken for a hamartoma, particularly when the patient is a child. The prognosis is generally good for a mastocytosis alone, whereas it is poor for a mast cell leukemia and poor for a malignant sarcoma. In this one, courtesy web pathology, it is a cutaneous lesion. Find the nodularity that could be appreciated very well. And this is the reference for the entire article that I have narrated so far. When even cells are multifunctional, why not human beings? And look at this one. There is obviously a multi-personality disorder. Pure Robbins very beautifully says the schizophrenic cell is the endothelial cell. It can cause both thrombosis as well as antithrombotic function it has got. Similarly, you find every cell has got the pro and the con of it. Similarly, the basophil and the mast cell, we've got a plethora of functions, and where is the origin, etc., we do not know. But obviously on the screen, I am seeing three phases of the same multifaceted personality. Thank you for your patience.